Okay, good afternoon. Everybody's feeling hopefully full and maybe not too tired. We're going to do a discussion of retrograde nail lengthening particularly. And I'm going to highlight some experience that we had in a study that is going to be published very shortly. So the indications for the retrograde nail, in my opinion, are when the antegrade nail cannot be used, or if you want to simultaneously correct a distal femur deformity, if you want to do a staged total knee replacement, and there's some, you might do it that way. This way you could take out the nail and do the knee replacement at the same time, or if you want to lengthen below a proximal femur reconstruction. But otherwise, in my opinion, the antegrade is sort of the standard technique. This is an article in JBJS Surgical Techniques on the retrograde technique, which you may find helpful. So here's an example of a patient who was sent to me by one of my arthroplasty colleagues at the hospital, and you can see he's got advanced arthritis of the knee, but he also has a leg length discrepancy of 35 millimeters, and there's also some sagittal plane deformity that was felt to be necessary to correct. And so this is a good case for a retrograde, I thought, because you can correct the deformity. You can see we corrected the sagittal plane deformity. You'll notice the blocking screw up at the top here. We got the length back, and he's set up for a staged total knee replacement if he wants to. The interesting thing is that when you correct some of these deformities, you'll find that the patients feel a lot better, and they may not be necessarily interested in the total knee replacement so quickly anymore. And so, in many cases, you will delay that more so. But here, the blocking screw was helpful to correct the procravatum deformity that you saw. Here's an example. I think this is very similar to the case that we're going to be doing in the OR shortly. You can see this is a person who has distal femur valgus deformity on the left. Mechanical axis planning allows us to determine that there's a 7-degree deformity, right? And of 7 degrees of mechanical axis varus. And then I put in that 7 degrees into an anatomic axis planning, and then we figure out the direction of the nail in the distal segment. We're not going to go past this proximal bow, so the nail is going to be a little bit short, right? So you can figure out your short nail length planning based on the osteotomy level, which here is 75 millimeters, plus the amount of length, plus, to figure out what's the shortest nail that you can get away with, okay? And again, reverse rule of thumbs is helpful. I put my blocking screw in first. You can see it. I do my entry. I figure out the direction of the nail in the distal segment, and this very much, you plan it, and then you have to recreate that in the operating room. So I think that's a key point. But you use a fixator, you do the osteotomy, you correct the deformity, and then you ream in the corrected position. And then you leave the operating room with the bone corrected, and then you can see the lengthening, it progresses. So this is what we did on this side. You can see we got a nice deformity correction, and then on our opposite side, we did plating. So because one side was short and one side was not. This is a publication on retrograde magnetic lengthening. This may be a resource that you find helpful. I did want to use this as an opportunity to show a little bit of data, and on using this technique of simultaneous deformity correction. And so, as has been mentioned, it incorporates the principles of fixator-assisted nailing, and it also incorporates the principles of blocking screws. So in this particular study that is going to be published in Journal of American Academy of Orthopedic Surgeons very shortly, it's a series of just retrograde femur lengthenings with simultaneous corrections. And so we wanted to look at the results of this and some of the technical considerations. It was a multi-center study, and these were the collaborating surgeons, 4 LLRS surgeons, all acute deformity corrections, fixator-assisted, and then gradual lengthening. We had an average of 27 patients with an average age of 28 years, and with an average follow-up of 13 months. There were patients with distal femur valgus, there were patients with varus, and there was one patient that also had external rotation, and also one patient that had a sagittal plane deformity. So this is a typical, this is a summary of what the pre-op deformity was. It was an average of 22 millimeters of deviation, 7.6 degrees of deformity, and an average of 31 millimeters of leg length discrepancy, with the PDFA averaging 82. In surgery, you can see the average blood loss, the surgical time for the cases. There were, when we did the fixator assistance, some cases had 5 millimeter pins, some cases had 6 millimeter pins, and you'll see that the reason we're making a distinction between that is that we tried to show that that would had some kind of an impact on the ability to accurately correct the deformity. The average number of blocking screws was 1.3, latency phase was 5 days. So our post-op results, in the end, the leg length discrepancy was an average of only 8 millimeters. 93% of the patients were corrected to within 3 millimeters of MAD 0. The average amount of lengthening was 30 millimeters, and there were no problems with bone healing. And 81% of the patients had mechanical axis restored to normal, and the average correction was 7 degrees, but the maximum correction was 15, and you can see the average joint orientation angles at the end of the correction. Knee range of motion really was not an issue. You can see there were some mild temporary contractures, but we really did not have any change in knee range of motion with this. But again, to the point that was mentioned, these are relatively small lengthenings, no really big lengthenings. And this is the typical range of motion at the end. They were full weight bearing within 89 days. The Paley scores were noted, and there were really no complications in terms of infections, fractures, or insufficient regenerate, and no mechanical failures and no joint dislocations. So what were the complications? We had one patient who had a premature consolidation, one who had a knee flexion contracture temporarily, one who had a little bit of subluxation. These were all temporary complications. Now, we tried to dissect the results a little bit and see if there was any difference between the varus and the valgus patients. And you can see here, really, there wasn't a difference between these two different groups when you looked at the corrections of the varus and the corrections of the valgus patients. That's the pre-op, and then you can see here the post-op. It's very, very similar in terms of the different groups. There wasn't anything significant about that. There was a little bit of a difference in that we found that the patients who had thicker half pins that are used for the fixator had better, more accurate correction of deformity. And so this was actually something that was a significant difference in terms of the half pin size. And the same thing with blocking screws. No surprise that this was the distribution of blocking screws, either 0 or 1 or 1. In other words, the point is that if for patients who had more deformity, right, then a higher percentage had fewer blocking screws. So the take-home message is that the more blocking screws you use, the more accurate your deformity correction is going to be. And then this, we looked at different nail sizes, small nails versus bigger nails, and it turns out that nail size also had an impact. As you can see, the smaller nails, right, the 8.5 nail had higher rate of deformity, and as you got into the bigger nails, they had less deformity at the end. So the take-home message, again, is use the biggest nail you can to fill the canal. So in conclusion, what we basically found is that it was a successful technique using this technique of acute correction, using fixator-assisted, using blocking screws with minimal complications. And all patients had leg lengths restored. You can see within 6 millimeters, within 3 millimeters, no complications is noted over there. And also very effective correction of the mechanical axis, right? Not much different, varus or valgus. But potential technical tips are that a bigger half pin, 6 millimeter half pin, multiple blocking screws, largest nail possible, and over-aggressive return to full weight bearing. Using those kind of features gave the best results, the most accurate corrections of deformities. So another couple of examples. You can see here the planning, 11 degrees of distal valgus deformity. Right, you can see the orientation of the nail that's necessary in the distal segment. You can see by that blue line the extension of the tibial line upward, right? And so that you're gonna have to recreate that. And so the blocking screws are placed. The blocking screws are in the concavity of the deformity. You see the fixator pins. You see the multiple drill holes have been made. You can see the path of the nail with the retrograde reamer, right? The osteotomy is done. The deformity is corrected. It's held in place with the 2-pin X-fix. Then the guide wire is passed. The reaming is done. And then the nail is placed with acute correction of the deformity. And then the lengthening then follows. Now, admittedly, I don't pay a lot of attention to the reverse planning method. I haven't really taken into account the additional lengthening. And I think in practical terms for these 3-4 centimeter lengthenings, it's academic. I don't think it really has a significant impact. I think doing this, we've been able to get really nice, accurate, without really adhering to that whole reverse planning methodology. But this is sort of a typical example, and I think this is similar to the case that we're going to be doing in the operating room today. The other indication I mentioned is below a total hip, right? So this is a young woman who had a total hip. She has 7 centimeters of leg length discrepancy because she had a femoral shortening osteotomy, and this works very well by doing a retrograde. This was such a small bone and such a big amount of length, I actually needed to do it in 2 stages, right? I couldn't do it in 1 stage. So stage 1 is over there, you can see, and then once we got healing, the first lengthening was 4 centimeters. Then I took her back to the operating room. I left the blocking screw in place. I did a second osteotomy just adjacent to the first regenerate, and then we went in and put in a second nail, right? This is my second osteotomy now, and you can see the lengthening, so it's stacked lengthenings, one lengthening over the other, and that allowed me to get 4 plus 3 equals 7 centimeters of length. We actually put this little experience together also. This is a paper that's coming out soon where we had 3 cases of lengthenings below total hip replacements using this retrograde technique, and you can see the average lengthening was 40 millimeters, and it's sort of the idea that you can on these complicated cases that have big shortenings, they get some length from the hip replacement, but any residual length can be taken care of with this retrograde technique.